Yeah, so to start with, I would like you to give us an overview of sexual dysfunctions. What are sexual dysfunctions? What do they look like in men and in women? What are the common types?
Okay, so sexual dysfunction is any sexual complaint, okay, by any individual, bordering around desire, arousal, orgasm,
Okay.
and sexual pain, which causes distress to the individual, or causes an interpersonal difficulty between that individual and the partner.
Okay.
So, in essence, it means that if relatively there's a problem and it doesn't give patients in distress or the partner a difficulty, you can't really say there's a sexual dysfunction.
Okay.
Yes. Now, there are the types in men and women are in about the same categories, okay, and they follow that spectrum: desire, arousal, orgasm, and pain.
Okay.
And so those the types follow that spectrum. For desire in women, we have those who have hyperactive sexual disorder, those who have sex aversive disorder,
Okay.
that those who have orgasmic disorder, okay, and then pretty much in women, many women have the pain disorders. For instance, the vaginismus,
Yeah.
okay, that's common in new couples and many other people. For men, same. Of course, the very popular one is premature ejaculation, and that's has created a big industry for those who produce aphrodisiacs, sex booster, and all the likes.
So it's mostly
It's a big field on its own. Sexual dysfunction is a big field.
thank you, Dr. Taiwo.
Yeah.
All right, Dr. Taiwo, thank you very much for the explicit explanation. So we'd like to know what are the causes of this sexual dysfunction.
Okay, so the causes of sexual dysfunction is a lot. I will start by saying that sex starts from the mind, and anything that affects the mind or the brain would eventually affect the sexual response of a man or a woman. So that means that starting from there are psychological causes. Okay, some are caused by nature. Those who from depression, learning disorders. Those who have just had some post-traumatic stress disorders. Okay, there are also biological causes. Those who have underlying medical conditions, hypertension, diabetes, connective tissue disorders. There are local causes, that's causes happening at the site of that or in the organs of sex, and more of those will include the pain disorders. Okay, so those who have the vaginismus, those who have ambiguous genitalia, and the rest of that. So many causes in that regards. There are hormonal causes, there are infecting causes, there are endocrine causes, there are chemicals that mediate our response to sex. Every time someone wants to have sex, there are controls in the brain that facilitate that. Okay, first is the motivational components, the motivational the cognition. The cognition says that this is a sex stimulus, okay, and I should go for it. Motivation means that this is cognition means that this is a sex stimulus. That means I can recognize this as a sex stimulus, either advances from your partner. Motivation says this is a sex stimulus and I should go for it.
Okay.
Now, physiology means that your body now says, my mind is ready, my body needs to go for it. So there are changes in the body, the flushings, all of the butterflies in your tummy and all that thing. There are distinct responses in your body. So that's the physiological component. And there is the inhibitory component. meaning that you see this as a stimulus, but you think I should not have sex in this condition. Let's say the person is not your partner, or the location is just not right. You can't just come into a reception like this and say you want to have sex. So and that's because the inhibitory component of the brain is working. There are those that don't have that inhibitory component. They say they are disinhibited. So if they feel like having sex, or some of them are in psychiatry departments. So anything that will affect those controls will affect response to sex.
Can the process be congenital?
Oh yes, it can be congenital. There are those who have anatomical, by that I mean structural issues with their genitals. Those definitely will have some kind of sexual
dysfunction.
Okay, and most of these congenital issues have to do with how their chromosomes, form when they were given birth to chromosomes that make us up. Okay, so when there are those things, then things like that can happen. Okay, and then for instance now, for those who have the pain disorders like vaginismus, there are those that have been diacetic, okay, or those due to psychological reflexes, that those are really acquired. People who had traumatic birth experiences, okay, and maybe they had tears that were not properly closed, or there were some defects here and there. Those people can end up having a permanent sexual dysfunction if some of those things are not corrected. So they are congenital and acquired causes in most of the spectrum.
Mentioned and range of the potential causes, like this could be this, could be that. But I'm very sure that in medicine, to be having any of those and not having erectile dysfunction or sexual dysfunction. So how exactly can we diagnose anyone that has a sexual dysfunction?
Okay, so we get to that point where we say what make a diagnosis because someone presents and says, I have a problem with my sex life. So most of the diagnosis starts with history, the complaints that the patient gives. Is it that I ejaculate fast? Is it that I don't achieve orgasm? Is it that I have pain during sex? Is it that I don't even want to have sex at all? Those complaints I just mentioned already are stratified the kind of sexual disorder. If I have pain, it means I have a pain disorder. If I say I don't reach orgasm, it means I have an orgasmic disorder. If I say that I don't have desire for sex, it could mean that I have an hyperactive sexual disorder or an aversion disorder. Okay, so when we get to that, then we can now go ahead to ask questions around their psychological life. How's your life like? What's your work like? Are you married? Do you have some satisfaction with your partner? What was your past like? Are there stressors? Do you have an aged parent that needs some medical care, is about to die? All of those things come into play when you're making a diagnosis of sexual dysfunction. So the questions we ask is all encompassing, and then go ahead to examine them, check their affects. Some of them have this blank affects. They are disinterested in life. Someone who is disinterested in life can
I'll be interested in sex. Yeah, true.
You examine them, check their body. Is there blood pressure? Is there diabetes?
Okay.
Are there facades or physical expressions that would suggest that they have a medical condition, just like the medical conditions I mentioned before? So he do that. And then the genitals. Okay, some could have tears that were not repaired properly. Some could have vaginismus. Okay, some could have lesions on the genitals, male or female, either sores or ulcers on the genitals. There are those who don't even have the genitals to start with.
There are people like that?
Yeah. And there are those who have double genitals. Okay, they have an elaborated clitoris that looks like a penis, and they still have a vagina. So there's no way those kind of people have a satisfied sexual life. So examination is there, and then where to do the tests. Several of them.
All right, doctor. So you've affirmed that there are tests to ascertain if someone has sexual dysfunction or not.
Yes.
So are there treatment options? What do these treatment options look like?
Okay, so the treatment option covers an array of many modalities.
Okay.
The mind, the body, even environmental modifications.
Okay.
So starting from the mind, a number of them, even when they have the underlying medical conditions, still need some light therapy.
Okay.
So you will never go amiss doing some psychotherapy for people who have sexual dysfunction.
Okay.
Yes. A lot of those who have vaginismus, for example, could be that they've had a bad experience in the past. So, when they're about to have sex, by reflex, that thing just happens. And then the pain, shows up, and then
That's
very grounded for that night. So, you want to make sure that their mind is intact. Okay, so this is where the place of cognitive behavioral therapy, psychotherapy, counseling, comes into place. And that does a lot. Even for someone that has premature ejaculation for medical issues, real medical
issues.
Okay, if you treat the medical issue and you don't treat their mind, you will not get
The results.
optimal results. So psychotherapy is a big thing. Okay, and then there are other things. One, check if the underlying conditions, those that can be treated should be treated, like hypertension, diabetes, connective tissue disorders. If they have lesions or the genitals, it should be treated. Some with drugs. There are those that need surgical intervention.
Okay.
Maybe you need to repair some defects, or you need to cut out some, painful lesions that give them pain. There are adjuncts, like the use of lubricants.
Okay.
Lubricants can ease out a lot of sexual incompatibilities between partners. Lubricants, that
Device.
vibrators, devices, vibrators and all that. Even those who have vaginismus, sometimes we go ahead to do serial dilation for them. So, places tight, they do a serial dilation till they are able to achieve, a good sexual life. So there are chemical, non-chemical, there are surgical, those I've mentioned, or some of those I've mentioned. Also, for those who it's age catching up on them, like women who are postmenopausal, they can use the lubricants. Some of them, we do what we call a hormonal therapy, like I can add back. So what we are trying to do is that, yes, we know you have achieved menopause, but we want to, by, chemical-wise, get you back to what you were before you got to menopause. That's going to affect your sexual life. There are gels, there are drugs, there's a lot of them.
All right, thank you very much, Dr. Tayo.
Thank you.
So you made mention about treatments. So I would like to know your view on aphrodisiac. And also, I would like to know if there are myths surrounding sexual as a dysfunction.
Okay. So we'll do the pros and cons. So I don't, causing bad markets.
Okay. That's important
for those who produce them, because the truth is they've helped some destiny, they've helped some lives. Folk foods, but have gone their separate ways if not for them. Okay. Aphrodisiacs, even in sexual dysfunction, as medical doctors, we sometimes will give aphrodisiacs.
Okay.
Yes. There are specialists who have to recommend some aphrodisiacs to men, to women. Okay. Where I think the dividing line can be is whether the aphrodisiacs are orthodox drugs or medical products. Okay, but there is the role of aphrodisiacs in sexual dysfunction. But first, you really should make sure that they are well psyched up for sex. Their minds is in that. If it is, then the sex will be fine. There are so many myths, and that is why I think the market is booming. With a lot of these medications, the fact that you have to get on it for 3 hours before you can have fun. The fact that your organ has to be like 14 inches long, and all of those things, and it puts people under pressure, unnecessary pressure, needless pressure, because someone feels that I don't get as much, you should be doing this for 3 hours. And then the poor man is under some pressure. Okay? And then the man also complains that, the packageway is not tight enough, or it's not enticing. And then the woman too is under pressure. So you don't have to be there for 3 hours to get to orgasm. What we want to do is start the journey, get to orgasm, and end the journey. Basically, as far as the partners are satisfied and have had a good time, then that's enough. I won't be going to the doctor to compare our sexual dysfunction. Okay, but if you want to do a comparative analysis, you want to compare your company, okay, with another set of people who maybe though way up in the roof, then you are going to get some trouble for yourself, because all these drugs have their side effects, okay, and they have metabolic significances as well. So if you are going to use those drugs, you make sure that you get there on the recommendation of a physician. Okay, if there are other background causes that you should look into them before you go the way of aphrodisiacs. Yes.
All right. So as a closing remark, doctor, I would like you to talk to us about the shame surrounding sexual dysfunction. What should people do when they have sexual dysfunctions? Should they talk to their partners? How do they walk around the shame that surrounds sexual dysfunction?
Okay, so the thing about shame is to first tell yourself that there is no shame. And why there is no shame is because these things are underreported. A lot of people have this problem. Okay? By studies, there are several studies. Globally, we say like 40 to 80% of women have some form of sexual dysfunction or the other. So the fact that you think that you have a problem doesn't mean someone else doesn't have that same problem. There are many people, so you are not the only one. That's the first thing to say. The second is that open communication between partners is very important. I think that if I buy a product, I should get a review. In the same vein, if partners have sexual experiences, they should review with the one they've done.
Yeah.
Have I done good? And then if there's a mismatch, if I think I'm the pro, I'm the professional, I'm the big man, and the lady thinks otherwise, it means that you both should just be a professional, talk about it, and then find their ways around it. Because most times, the stigma is more around, men having premature ejaculations or women not giving their men exciting in sex life. So communication is very important. When you communicate, you get to the root of things, and then you have a good time.
Welcome to Health Chat with Best Western Hospital. We'll bring you health tips and advice that are rooted in medical expertise. Listen to connecting stories about health, wellness, mental health, and everything in between.